Thank you. So obviously we're here to talk about genetics of obesity, and you've heard all about the manifestations of obesity and how it's a disease. Implicit in that concept is then, as a disease, is it mostly nature or nurture? And many people would approach this. Our patients may think might lessen some guilt that they feel, alleviate social stigma, which is very ironic as a geneticist because many genetic diagnoses, of course, carry their own stigma. And of course, the other part is recurrence risk in future pregnancies, which possibly doesn't occur to people if they're really focused on finding a genetic explanation for their problems. Let's consider some arguments in favor. Clearly, twin studies do show that perhaps the majority of adiposity is heritable, that even adoptees' BMIs correlate with their biological parents, not with their adopted parents. And indeed, if you have one parent with obesity versus no parent, you have a multiple higher risk of obesity yourself. And if both of your parents have obesity, then it's over 10 times the risk of obesity. That being said, which country has not seen an increase in obesity since 1975? I think we tend to focus more on who's had more or less, but in fact, the trend is common to all countries. And in genetics, we would assume that if there was variation, it would create more divergence, not convergence. So that's paradoxical. You can look at the regional variation between countries, within countries, that people of the same race, where perhaps we assume that international variation is somehow racially determined or dietarily or something. But domestically, more homogeneous populations still have very significant variation. What you do find is that the lowest prevalence is amongst groups with the highest income and education. I think you may be even seeing that in the developing world. And that's independent of race or ethnicity. So again, speaking against this being a genetic etiology. And when you do see some association with race, especially in our American data, for example, in the South, that is often confounded with social determinants of health, the built environment, again, what people are eating, etc. And the raw data of this transformation worldwide, this is WHO data, is that evolution doesn't happen on this timescale. Genes stay the same between generations. That's sort of the definition of genetics. It doesn't change like this. In fact, often we think of pediatric illness as being a sign that it might be inherited. That's versus acquired illnesses are generally adult onset. And even though we see a very strong change in the child population in the last 50 years, 1% were obese in 1995 versus 7% more recently. In fact, that just speaks to the fact that this is just an enormous change in the environment rather than having a genetic underpinning. Think of this statistically. So a selection of several normal distributions here. Each of these has a different variation, right? So the red has the least variation, the blue a medium amount, the purple the greatest variation, the range about the mean, where the orange has a lower mean and the green a higher mean compared to the blue. So let's put a line here that this line indicates obesity. Of course, with a lower variation, the red has the least number in the obese range and the purple the highest number of those around the mean in the middle. But in fact, that's not what's changed. What's changed is the mean. It's gone from blue to green, and now where a minority had obesity, the majority have got obesity. We're talking about a shift in the mean, not variation that might be genetically determined. So then why do we even bother studying the genetic factors if I'm making the case that I don't think obesity is largely genetic? Well, I think if we're talking about obesity being a disease of body weight regulation, then there must be some molecular mechanisms that govern weight homeostasis. If this was merely thermodynamics, then in fact there might be less reason to go and investigate this. one of the pieces of evidence that Mira didn't show, but I'm sure you've all seen, is that as you do an intervention, you lose weight, but then you regain. That's the great danger, and sometimes they gain even more, as was said, than they started with. That is evidence of this homeostatic process going on. If you conceptualize this, you can see that this nature versus nurture comes out here at the top. Both are contributing to both physiological changes and behavioral changes. We're human beings, we're not animals. We have far more going on than just raw chemical processes in our body. Our behavior is much more complicated, and yet, of course, you don't need to be a psychiatrist to understand that there are genetic underpinnings to behavior as well. And each of these interacts with each of the possible ways that weight could be affected, whether it be metabolic rate or assimilation of calories, and of course other behavioral changes. And so this is a conceptual diagram. I'm going to give you some of the evidence about where the majority of the genetic evidence is, but at least conceptually there must be much more interconnectedness than you might imagine. In fact, you saw yesterday also how the gestational diabetes example, where maternal obesity and undernutrition can directly connect environment with heritable traits, epigenetics, etc. So again, the paradigm of nature versus nurture, sometimes that's actually an artificial construct too. We have to recognize that things are more connected there as well. Let me just explain some jargon, because this confuses people, and I think it's actually helpful to understand it clearly. Genetics is that idea that there's heredity in traits. We think of this as single genes transmitting those traits, so Mendelian genetics, thinking about how sickle cell, for example, is inherited. Linkage is a typical way that was studied earlier, and then Sanger sequencing, versus genomics, where now we have technology that can look at the entirety of the genetic material. And that allows you to look at how things interact with one another as well as the environment. So you're starting to be able to capture lower penetrant variation, with the caveat, though, therefore, that it might be less predictable how it interacts versus a Mendelian trait. But truly, 23,000 genes across 6 billion base pairs in both sets of the 46 chromosomes. The other construct here then that leads to is we have monogenic on the left, polygenic on the right, and we want to think that the two are separate worlds, perhaps, that they clearly, I'm going to give you some examples of very prominent, unmistakable syndromes, and then the polygenic, where there may be no outward characteristics besides obesity, at least recognizable characteristics. And yet, in fact, the genetic studies that have taken place have shown that there is interconnectedness. There is no ability to draw a line between these two, that they blur into one another and exist on a continuum. So the classic way a geneticist would think of complex disease is by looking at this picture, really. We all know that height is inherited, but we also know that no zebra could ever grow as tall as a giraffe, that clearly they have separate abilities to grow that is genetically governed. Of course, parents, the height of children is going to be corresponding to the height of the parents, but you can't predict the height of your child based on the parents. In a given family, there will be taller and shorter siblings. And this is because there are many genes being inherited or not inherited in parallel, and that each child gets a random sampling of the parents' genes, and they don't each have the same set. And we also know that environment can render a child of short parents to be tall and vice versa. And so even though we know that height is inherited, weight is inherited, that doesn't mean that it's entirely so, and in fact doesn't even mean that it's mostly so. Another way to look at this is, you think of it as a quantitative trait. The number of genetic predispositions that you might inherit would tip the scale one way or the other. So you may get certain genes on the angel side from your father, certain genes on the devil side from your mother. But again, if you're in an obesogenic environment, that's going to tip the scales far more than some of the other. And of course, the picture shows them all of equal size. They're not necessarily all purely equal size. And it's impossible to know which is the single cause at that point. So the significance of that statement would be to say, in fact, investigating might even be futile, because you might pick out 3 or 4 things from 100, and then because you've named them, you're going to give them some importance and say, these are the 4 things that explain the obesity in this person. The fact is, you're probably missing 96, but you don't even know that you're missing them because they're invisible to you. And so it can be a sort of heuristic flaw that the ones that you know about become take on a significance that they may not deserve. In general, these are the clues that you consider referral to a medical geneticist for, in general terms, for any condition. Something that's early onset, of course, pediatric population, the severity per se, an unusual pattern of disease, or the family history. In fact, sometimes people see a severe case and they say, well, there's ironically no point in doing further investigation. So I'm definitely encouraging you that the extreme examples are the very ones to dig into further, both from a mechanistic perspective, just to understand the process of disease. There's a long track record of how geneticists and basic scientists have elucidated, pathways in the body and disease processes through studying families with extreme phenotypes. And another example that you've got now in the present day that you didn't have until recently with respect to obesity is resistance to therapy. So I give talks on when to refer to medical genetics for things like thrombophilias or things like cardiovascular disease. If somebody has an MI at 30 years old, they should get referred. If somebody has 5 blood clots by the age of 50, they should get referred. Now you've got the example, and especially if they're resistant to treatment, now you've got the example of if somebody doesn't lose weight on semaglutide and in fact has serially failed different treatments or even bariatric surgery, that might be grounds for further investigation. So I'm going to give you some extreme examples. We don't have much time, but some extreme examples of conditions that are associated with obesity to illustrate the fact that clearly there are biological genetic processes that do underlie obesity, but I'm going to give you some examples that are less clear and you'll be able to contrast. So Prader-Willi is often a headline example. This is a neurodegenerative disorder. It's caused by loss of the paternal imprint at the Prader-Willi critical region, which is on long arm of chromosome 15, 1,1 to 1,3. The parents are unaffected by this, but often assume that genetics inherited. In fact, it's very unlikely that any other siblings would ever acquire this. Not impossible, but very unlikely. The phenotype is across the body. So you see full muscle tone and feeding at birth, and then developmental delay almost as soon as milestones come in. They develop obsessive compulsive traits and tantrums, sometimes around food. And it's only around age 6 that hyperphagia becomes prominent. People think that that's when they start to experience lack of satiety. So they really lose that self-control. And then they start having very maladaptive food behavior, hoarding, foraging, eating inedible objects, and even stealing money to get food. But again, you see that there are digital changes. They do have centripetal obesity, no doubt, but almond-shaped eyes, and there are several others. So this is something that's obesity, but many, many, many things besides. Bardet-Biedl would be another headline. So this is a recessive condition, but heterogeneous, meaning there are maybe 30 genes that are known to be associated with this condition. So it's probably indicating a complex pathway. It's a multi-system condition as well. actually a ciliopathy and affects development across the body. Birth weight is normal here, but they get very early central adiposity. They also have blindness, intellectual disability, kidney malformations, etc. And micronathia, I haven't named that, but in fact, that's something you can see in the pictures there. People of different races, but all having that small chin as a kind of clear feature, despite the adiposity on the face. But undoubtedly, above all of these, the biggest driver of genetic obesity, if you want to call it that, would be CNS pathways. This is where the evidence has taken us to. CNS pathways control the hedonic aspects of food intake. And mostly identified genes are either enriched or exclusively expressed in the brain. So we really have got localization here. The named areas you can see associated with higher functions, learning, emotion, addiction, and reward, things that are, getting back to that earlier diagram, genetically connected, but via behavior, not via just intracellular processes per se. And of the CNS pathways, the leptin-melanocortin pathway has stood out as the strongest. In fact, variants in many of the entities that you're seeing on the diagram, we haven't got time to go into them, but many of these entities are associated independently with obesity. So very strong evidence that this is a key pathway in the body for weight homeostasis. Getting to specifically leptin and the leptin receptor, which was one of the earlier monogenic examples of obesity-associated variants. This is also recessive, so I've given you a recessive pedigree on the side here. You can see in the top example, yes, so the top example, these would be two unrelated families, and they've got a pretty high number of affected kids, 2 out of 4. A priori, we would expect that just 1/4, but of course it's random chance that each pregnancy is an independent event. In this illustration, they have 2 affected offspring. In the second example, you see something that's perhaps commoner in certain parts of the world, where in fact there's only one gene passing through this family, but that one gene from the original person at the top, the great-grandfather to the 2 parents of the offspring, is in fact passed down through the generations, and then these 2 second cousins are in a relationship and have, again, 2 out of their 4 children. Again, it would not be that necessarily, but that's what's illustrated. So this, of course, increases the risk of recessive conditions because it's not 2 genes coming together by chance, but the same gene that is brought together through consanguinity. So it does turn out that leptin has been quite well understood and well documented in Pakistan, perhaps because of that. But it's also rare, and the thing that really is exemplary about it is it was one of the earlier things I mentioned to be discovered, perhaps because it's such a dramatic phenotype. You see in consanguineous families perhaps multiple children affected, so the clues are all there that there's a genetic etiology here. But non-syndromic, besides obesity, there's really no other manifestations compared to the 2 I just gave you, 2 examples before. So leptin functionally is now understood to signal a starvation response. It's secreted by fat cells in proportion to their mass, and the levels decrease with food deprivation and return during refeeding. So it really is to limit appetite. Despite that, there's only been a few dozen cases of deficiency, but because it's actually got a replacement available, we've been able to show that it effectively downregulates the problem, and people's obesity can be eliminated by giving leptin replacement. So really closing the loop on the idea that the genetic anomaly can be overcome, and then the whole pathway functions normally again. The previous diagram you saw had 2 arms, and so leptin receptor is on both sides. Sorry. Never mind. But you see the 2 arms go by. So it turns out that the other ones on the left side arm, some of these other entities, they act through the melanocortin receptor, and that's usually agonized by melanocyte stimulating hormone, and we have an analog for that, setmelanotide. And for each of these, there's now FDA approval to give setmelanotide as a treatment. And it has variable efficacy in each of those. In fact, also giving evidence to the fact that they are different steps of the pathway, and the more proximate to the deficiency that setmelanotide is, the receptor that setmelanotide agonizes, the more effective. And the further back you go in the pathway, of course, there will be other intersecting signals that might reduce the efficacy. So a little bit less effective than the leptin replacement example. But as with many of these agents that can show weight loss in a genetic case, people might say, well, maybe we could trial its use off-label. Who knows what's the worst that could happen? In fact, those studies have been done, and there is no evidence that leptin replacement or setmelanotide help people without the genetic defects. So not advocating for any off-label use here. Another example of non-syndromic monogenic obesity would be FTO. So this was a nice example because it was discovered very early on once we began to have agnostic testing, so non-hypothesis driven testing. Some of the others, you see a family, you have a sense that there's got to be something there and you investigate. Here, this was done in random or at least populations where obesity alone was the only selection criteria. And it was found, this is on the long arm of 16, 12.2, and it's very, very common. So it's funny how despite being common, it hasn't been identified until we had agnostic testing. That to me tells me that its effect is attenuated. So it's an example really of something in the middle. It is monogenic. You might expect it to be on the left side of one of the earlier diagrams I showed you between monogenic and polygenic, but in fact it's of a lower effect. So it's really only showing up when we have this kind of very non-hypothesis driven testing. Nevertheless, it's very common, and so therefore it's had pretty good data. We know that it has a very negligible effect. You know, you see there about 0.35 of BMI per allele, so a homozygote may only have 3 kilograms extra, which you can see would not really generate any special attention if it wasn't for this type of testing. The mechanism is thought to be through cellular nutrient sensing. It's still unclear, but it's definitely associated with food intake. One of the examples is we have FTO deficient mice are lean, and those that overexpress are obese. And another part that may not be food intake related but hasn't been proven is there's one variant of FTO, not the common variant, but and a different variant that somehow triggers adipocytes to change from brown to white fat. So you might actually end up decreasing calorie consumption. Another one of the ways that genes can control overall weight, but that may not be the majority effect here. The nice thing about FTO was also in Denmark, they studied people who were both carriers and non-carriers. So people who were inactive, clearly those who carried it were heavier. But in fact, those who were active, and it wasn't a very high threshold, just I think self-reported activity, they actually found that there was no discernible difference in their BMI. Again, proof that these are gene-environment interactions, and in the right phenotype, in the right environment, people are protected, and in an obesogenic environment, perhaps more complications may arise. But exercise is not rendered ineffective just because there's a genetic etiology or contribution to a problem. Nonetheless, I'm not denying that there's a lot that remains to be discovered. We've looked at 750 loci at least from genome-wide association studies from almost 1 million people, and they think only 6% of the BMI variation has been explained. From a genetic perspective, that doesn't actually surprise me. For those of you who followed genome research, there are probably about 20,000 coding genes in the human, which is far less than most mammals and far less than some plants. So how does a human being have fewer genes than so-called lesser organisms? Well, because it's not that the number of genes is not what governs the complexity of a human. There are clearly other mechanisms at play. Alternative splicing is probably the most powerful that we recognize, but functional RNA as well. And between those alone, there's more than enough opportunity for other ways for genetics to influence all manner of phenotypes, including obesity. But the reason I bring it up is we are at the level right now where we're focused on coding areas and recognize genes. So if that's where our attention is, and if that's not where the money is, then naturally we may be missing 94% of the explanation. Thank you.